welcome to today's Caregiving Essentials Webinar, Caring for Complex Seniors, Advice from the Frontline. I'd like to begin, as always, by acknowledging the land on which we reside, McMaster University. I'm up here in Ancaster at my house working from home today, but all in the area of which we reside is recognized as being on the traditional territories of the Mississauga and Haudenosaunee Nations and within the lands protected by the Dish with One Spoon Wampum Agreement. My name is Christine, and I'll be your host today. And on behalf of McMaster Office of Alumni Engagement and Continuing Education, I'm thrilled to have Donna Thomson back and a wonderful guest, Dr. Nathan Stahl. Before I begin, let's do the logistics. As you all know, if you have a question or comment, feel free to type that in the chat. The one wonderful thing for those of you who are new to the webinar series, the chat is open and feel free to share any information that you might have, but just be mindful, it is public, so you might not want to put anything too personal in there, but we love when people share their experiences so that others can gain inspiration from that and help. Questions. So if you have questions, feel free to put that in the icon. We had so many fantastic questions that were brought in. I don't think we're going to get to nearly even half of them. When I say a lot of questions, like I mean probably like 65 questions we had. So thank you everyone for submitting those. And as usual, Donna will weave some of those questions into the presentation. But we'll try to get to a few questions too if you want to put those in the Q&A. And as always, this webinar is being recorded. So if you want to share it or rewatch it afterwards, you'll get the link to the recording and you can watch it at your leisure. So Donna Thomson. Donna is a caregiver, author, and educator. She is the author of 2 best-selling books on caregiving, including The Unexpected Journey of Caring. She is also the facilitator of the online course for caregivers, the Caregiving Essentials course, and this is the webinar series that is a supplement to that course. And she's also a co-designer and co-instructor of the Family Engagement and Research course, both of which are at McMaster. Now, Dr. Nathan Stahl. Now, Dr. Stahl, I have to say that after reading your bio, I feel really unaccomplished. You're both a medical doctor and a PhD. You did your residency in internal medicine, and then you followed that up with a fellowship training in geriatric medicine at the University of Toronto. You then, because that wasn't enough time, doing schoolwork, you then completed a PhD in clinical epidemiology and healthcare research at the Institute of Health Policy Management and Evaluation, again at U of T. Your research includes large administrative databases to study Ontario long-term care system, the population health impact of caregiving for dementia, drug safety for older adults, sex and gender-based determinants of aging, and healthcare utilization among peoples with dementia. You're also a staff geriatrician at Sinai Health, since 2017, and you're a clinical scientist and assistant professor in the Department of Medicine at the U of T. You're also, you attend to inpatient geriatric medicine consultant services, outpatient geriatric medicine clinic, and the internal medicine clinic teaching units at Mount Sinai Hospital. So with all of that information, everyone should be should feel very comfortable that you are very well versed in the topic tonight, or this afternoon, dealing with complex seniors with complex situations, given both your medical profession and your research profession. So thank you. I know you are very busy, so it's great that you have us here with us today. And Donna, I'll let the two of you talk.
Awesome. Thank you so much, Christine, and welcome, Nathan. I'm so excited to be talking with you today, especially about a topic that I know you and I care so deeply about. And we just had a similar conversation very recently at the Canadian Centre for Caregiving Excellence conference, where we were both on a panel about complex care needs in older adults. And, on that occasion, we took sort of the umbrella, the big tent approach, and thinking through adult complex care generally. So there were some people on that day talking about complex care youth transitioning to adult, from pediatric to adult care. And I think we can sort of allude to the big group of adults with complex care needs and figure this all out. But first of all, I want to ask you, Nathan. So you're a geriatrician, and you're I will say, a big famous geriatrician in Canada. Certainly people who pay attention to your field really hold you in high esteem. How did you get interested in geriatrics?
Well, thank you. And thanks so much for hosting McMaster, and thanks for inviting me, Donna. It's a real pleasure to talk about such an important topic. And thanks to all see out of the corner of my eye, I see over 200 attendees, 220 attendees. So it's really amazing that so many people have tuned in. Yeah, so, I often say, oh, I'm a geriatrician, and many times, even in the hospital setting, people ask, well, what is that? Is that, people are not even certain that it's a physician's role, which is fine. But across Canada, there's actually only about 400 of us now. And in Ontario, we're approaching somewhere around 300, but it's a very small number. So, and in Canada, we have approaching about 100,000 physicians. So you could see that we are a very, very small number of doctors in Canada. That's alarming for a number of reasons. Notwithstanding the fact that in 2016, the number of seniors in Ontario and really across Canada overtook the number of children 14 and under, and we have over 10 times more pediatricians across our country than we do geriatricians. So that's not to say that other physicians can't and should and do have expertise in care of older adults, but there's a real deficiency in terms of our numbers, and we've acknowledged we'll never be able to have enough geriatricians to care for all older adults. So as we'll talk about today, we need to increase the capacity and the competency of everyone to look after complex seniors. That being said, my personal story, I actually, because it's such a sort of relatively unknown, I think like many things in life, there's a lot of serendipity, right? And so I did my internal medicine rotation. And so that's another sort of term we use, but internal medicine broadly is, when people come into hospital and they're too ill to be looked after in the outpatient setting by their family physician or their outpatient providers, and they're an adult, they require an internist if they require hospital admission. And there's general internists who look after sort of general health problems that require hospitalization. So, that could be pneumonia or heart failure. And then there are subspecialists of internal medicine, whether it's a cardiologist or a respirologist or a gastroenterologist, to name a few. So I actually did my internal medicine rotation first because I said, I don't want to be an internist. I wanted to be a psychiatrist. And I had an attending physician. I actually went to medical school at Western, who was a geriatrician. And I said, I really like this. It combines a lot of what I like about psychiatry and the brain and mental health and neurology, but also the medicine part I actually really enjoyed, and the complexity of that. And I sort of thought about the rest of my life in terms of, I'd always had very close relationships with my grandparents, and I also wanted to focus on a patient population that I felt was underserved. And so I had done initial work actually going to south of India and to Tanzania to do research on tuberculosis and thought about global health. And I said, well, we have this whole population that are right in front of us. They're some of the largest consumers of healthcare resources. We're seeing them every day. No one really wants to go into this specialty. I quite like the patient population. I quite like the medicine and the complexity of it. And so it seemed like a very natural fit from that perspective. But also, and as we'll talk about today, some of the really deep, meaningful questions about our healthcare system and about our society are focused on older adults. And so to be able to, have frontline experience to contribute to that also felt like an incredibly important opportunity to take hold of. So that's sort of my personal journey into geriatrics.
That's so interesting, Nathan. I never knew that you wanted to be a psychiatrist, but I can see where all of those threads kind of come together in geriatrics. And it's interesting because I've always thought that sort of the most difficult cases in healthcare, figuring out how to crack those will help us with the whole of healthcare. And I think in terms of the complex needs of older adults, that's one of those very intractable issues that we need to tackle. And people are not being well served today, but we will get into this. The first question that I wanted to just talk about immediately is, what are we talking about when we say complex care? And you and I were just discussing this before we went live today. And we were talking about one definition that we like from Dr. A.L. Cohen, who's head of the complex care team at Sick Kids Hospital, who defines complex care as serious chronic conditions, substantial functional limitations, and increased health and service needs. But is there anything that you want to add to that in the context of just your experience? And when you immediately think of complex care in your practice, what are the first things that you think of?
Yeah, so one of the things that I was remarking to you was that I think, there's a complex care clinic at Sick Kids, and there's a certain population that meets eligibility for that clinic. The same thing doesn't necessarily hold in my world, right? I think most patients we see are complex in their own way, right? And I know that sounds trite, but it's genuinely true in terms of older adults that, the overlap between cognitive and functional and health services needs, that is absolutely there. I would add, and I don't think Dr. Cohen omitted this from his definition intentionally. It's probably he wanted to think of some sort of concise definition for it. The other things that I frequently encounter are mental health and psychiatric comorbidity and complexity, social complexity, right? So particularly when we're dealing with issues of finances, of capacity for where someone's going to live and how they handle their money, of medical decision-making, and also fundamentally a place for these people to live where they can be best cared for. But I know we were having these conversations at the meeting in Ottawa. You really hate to, there's some opposition about homogenizing the sort of disability community, right?
Yes.
And we talked about, well, there are merits to uniting it because of the overlap, and you can do that without sort of both, and I think I used the word, with both infantilizing older adults and also geriatricizing, which isn't a real verb, but the children population, that these are fundamentally distinct populations. They require different expertise, but in terms of the overlap and the needs, in terms of that social complexity, the health service needs that they have, the need to have a health system that has time for these individuals to really be able to unpack and to deal with multiple and intersecting issues. There's where there's a lot of overlap. And so, it'd be hard for me to say that I have a unifying definition for the patients that I see, but often it's that approach to complex care that I see as unifying. That when I see a patient in my geriatrics clinic, or I see a frail older adult in the hospital, I have my consult that I do as the unit of work for the payment from the Ontario. I'm in Ontario, of course. It's 90 minutes, right? And you can think about, well, a family doctor does not usually have 90 minutes to spend with one patient. But in 90 minutes, and with the assistance of an interdisciplinary team, I can learn a lot about an individual. And so it's not just, one issue for 10 minutes, right? It's the fact that I can understand the totality of their past medical history, their medications, not just their medications, how they get their medications, how they take their medications, how's it supervised, what are the other things in their life that intersect with their health issues that are influencing their wellness. So often it's not they come in with a list of drugs and with past medical history, but it's the things that I uncover in that interaction by interviewing them and by interviewing their healthcare providers. And you realize, well, their greatest impediment to their function and their quality of life is actually the fact that they, maybe their driver's license got taken away and no one's helped them actually apply for Wheel-Trans because they're blind or they don't have computer literacy, right? And so, that's the complexity, and it's the time, just like the complex care clinic, to have time with people to figure these issues out and to support them longitudinally over time, as opposed to the specific individual components that make someone complex. That's the way I would answer that question.
I love that answer, actually. And it does provide a way forward in that conception, I think, to blend these populations where there are similar challenges. And, I was talking about this webinar online yesterday and today, and I've been promoting it for a while. But I heard from Dr. Sharon Anderson at the University of Alberta and her wonderful program with Dr. Jasneet Parmar, caregivercare.ca. Shout out to Sharon and Jasneet. They've created a free online training program for clinicians across allied health in helping them understand how to support family caregivers. But Sharon was saying that she had a conversation with a physician in Alberta who is treating older adults with complex care needs. And he said, it's so frustrating because what he has to do is choose one diagnosis that results in a healthcare pathway. And when there are multiple diagnoses, that's very difficult to do because there is no complex care healthcare pathway for patients. And I wondered what you thought about that.
Yes, I think what Dr. Anderson is hearing is unfortunately absolutely correct. There's our healthcare system was. And Andre Picard spoke about this at the event that we attended. He's written about this on other occasions. And of course, Andre Picard is a Canadian author, arguably our most eminent health reporter and journalist in the country. When our healthcare system was designed in the 50s and 60s, life expectancy was 20 to 25 years shorter, right? And geriatrics was a new specialty at that time because people didn't live that long, right? So even though we look after the oldest of people, we are actually one of the youngest of specialties. Of course, pediatrics is a specialty that's existed for, many, many, many years because there have always been kids. There have never been this many people living this long. And so I think what we are seeing in terms of that inability to have a system that has the slack in it to look after complexity is a reflection of how the system was designed, right? And where resources are prioritized. So, in an ideal world, and I've spoken about how, we'll never have enough geriatricians. Like it would be totally unrealistic and impossible to, and I actually don't think it's the right approach to train geriatricians to look after all these complex older adults. There's an education component to this in terms of, providing care and competency. And I spoke about this up front to all clinicians who look after adults to be able to care for complexity and to care for the geriatric issues. And, an example of that at my hospital, Mount Sinai Hospital, is we've created an orthogeriatrics model. So when an older adult comes in with a hip fracture, they're not only seen by the orthopedic surgeon, who of course does the most important job, which is to fix their bones, but they're seen by a geriatrician who works on preventing delirium, managing geriatric syndromes that emerges, working on preventing future falls and strengthening their bones. But within that, we've now had the orthopedic surgeons rotate on geriatrics for a month. And so our model, candidly, has almost become a little redundant because we've now been able to increase capacity and competency for our surgical colleagues, so they're able to do a lot of the things that we were doing hand in hand with them. That's one example. I think the other thing, and this has really come into focus over the last couple of years, is we have a real crisis of primary care in our country, right? And let alone the 15 to 20% of Canadians that don't even have a primary care physician, right? We know that primary care doctors are burnt out. They're burnt out for a number of reasons. Their roster sizes are big. The administrative demands that they have are huge. There's a lot of unattended to illness, whether it's preventative or mental health, that's a consequence of the pandemic. I fundamentally believe that one of the best investments governments across our country could make is to ensure that everyone has access to team-based primary care, right? And that would be ideally the model where you would situate complex care of your patients within. Because as I said up front, each patient at its essence, particularly in older adults, are complex in their own way. And doctors are just one piece of that. It's the allied health team that are arguably and many times much more important. And that access to a social worker or a physiotherapist or an occupational therapist, if you're not part of a team, then you're relying on patchwork of government services and supports that are oftentimes limited, that are not well served to provide longitudinal allied healthcare. And so, yes, Dr. Anderson is absolutely correct that the model of our healthcare system, particularly the model of primary care right now that we have, and the really focus on resourcing acute care centers, which provide episodic care that doesn't extend within the community, does not well serve this population.
Yeah, I couldn't agree more. And, we're going to get into the granular stuff about how do we fix this problem. But it's interesting. I reflect on my own family experience, trying to get interdisciplinary help for my mother, who lived with dementia until the age of 96. And then our son, Nicholas, is 35 now. He has extremely complex needs. He moved out of our home at age 23. He's 35 now. And he has one-to-one awake 24-hour nursing care. So his needs are highly complex, and we're very fortunate that we have a team in the community caring for him. But I would say that the nurses also who look after him are highly skilled in complex care, and they are our kind of go-to people, partners in assessing new symptoms, and the nurses are the key, really. So it's interesting the way it evolves. And this is kind of accidental. What works, people, and I see this in caregiver forums all the time, that somebody will connect with an individual who has a particular skill or a willingness to work together, with this population that is chronic and challenging and difficult and takes more time than billing codes will allow. But they say, yes, I will take this patient. I will work with you amidst uncertainty, and we'll figure it out together, which is music to the ears of everybody who's attempting to care for someone. But I wanted to just go to the questions that we got for a second, because we got quite a few questions about one element that I think is probably very common in the population you serve, which is where you have a cognitive impairment that negatively affects insight and decision-making, and where you have people who are, parents or older adults who are stubbornly refuse treatment or to acknowledge any kind of vulnerability, and which results in very poor and dangerous decision making. So how do you deal with that? People are really looking for just some basic practical advice.
Yeah, this is a tough one. I'd say to your first part, and I'm going to tie it into what I would call moral distress on the part of the practitioner. One of the things that we've, as healthcare practitioners, not unique to physicians, that we are all increasingly experience as a system, is moral distress that like we want to be that one person for that family, but there are also hundreds, if not thousands of other people that are waiting for our services, right? And that we also need to serve. And so the system is not only failing them, but it's failing the practitioners that put them in a position where we feel that we can't do the totality of things that we need to do for our patients and for their families. You know, the issue about cognitive impairment and decision making is a really tricky one, and we do deal with this all the time. You know, our healthcare system and medical ethics, I believe rightly, is set up to have an extremely high bar for taking away someone's capacity and their autonomy. And we need to do that because, you know, we need to respect as a primary principles a patient's autonomy. And when we talk about capacity, it's the ability of an individual to understand and to appreciate a decision that they're making. And that capacity is dynamic. They can be capable today, they could be incapable tomorrow. And a disease like dementia or any other disease doesn't make you globally incapable. So you could be incapable to manage your finances, and you could be capable to decide where you live. But one of the things that you highlight that causes a lot of distress is we are allowed as human beings to make bad decisions and to make decisions that others may not agree with, and to make decisions that you and I know are generally not within their best interest, but don't quite meet that threshold where they're going to harm themselves, and don't quite meet that threshold where we think that person is incapable. And that's because we set such a high bar for the ability for us to take away someone's ability to make decisions on behalf of themselves. I think that's the correct approach, but it does lead to moral distress because we know that, you know, this is the 5th time Mr. Smith has come into hospital. He's falling. His place is, you know, not clean. He's not managing meals correctly. But when you interview them and you talk to him, at the end of the day, he has a safety plan. He understands and appreciates enough to know what the situation he's going back into. And he understands and appreciates that he'd rather live in a bit of risk than enter into a nursing home. And so I know that's an unsatisfactory answer, but that's the reality of how medical ethics in our profession is set up. That being said, so if we assume that someone's capable and we respect that as a core principle, which we ought to do, we are still failing caregivers and those people because the system within the community is not well set up for them. So there are huge gaps in our home care system in terms of the maximum number of hours someone is able to receive. Generally, home care is, you know, if we try and advocate or make a referral for supervision, you know, to supervise doing things, it's unlikely to be accepted or in a very limited fashion. It's usually they have to have direct care needs, they have to have direct nursing needs, and where possible, it's to educate the person to be able to do it themselves, and then they leave. So there are huge gaps to allow people who we know are making a decision that may not, you know, may not be one that you and I agree with, but we could make it a more buttress system to make it a little safer. And relatedly, and I'm sure we'll talk about this, is we don't empower, educate, and I know you've done a lot of work on that, provide resources and also respite for caregivers who are struggling to look after seniors who are in these situations. So I think we need to hold on to that principle of autonomy and really respect it and maintain that high bar for capacity. But we need to strengthen our community and home care resources and be able to empower, educate, resource, and provide respite for caregivers so that they can better look after seniors who are in that situation.
Yeah, I think one of the problems is that when we prioritize autonomy and we support people in situations that are potentially harmful, like because an individual clings to being at home, even though you know, the person may be declining, particularly in insight around what's dangerous. I mean, I'm thinking of my mother who was a smoker and a drinker. And, you know, she smoked until the day she died at 96, but her dressing gown was full of burn holes and burns all on the carpet beside her bed. And you knew that this was eventually she got evicted from her autonomous seniors home. We know these are it's a ridiculous term to call, Chartwell homes or whatever, these seniors residents. People living in them are not autonomous, but they are supposed to be theoretically. So anyway, but the situation ended up being that we managed to get some help to identify a assisted living residence that was able to support her beautifully, and she was safe there. But as I'm reflecting on what you're saying about, we lack these home care community resources to support people and families in situations like this, the guilt falls on the family caregiver saying, I am the only one who cares enough to take a step, to take steps to prevent a tragedy here.
Mm-hmm.
And I don't know if the big centers like Mount Sinai offer kind of counseling and guidance to what are we actually responsible for in families? Can we forgive ourselves if something truly tragic does occur?
Yeah, it's an excellent question. I would say that we at Sinai have we have the carers program, which is specifically designed for people, for caregivers to look after people with dementia. And there's kind of an educational component, how to talk, how to engage, how to reason, how to de-escalate. And there's a therapeutic component, which unpacks some of that. But and certainly some of the sort of those issues of guilt and the mental health issues that may emerge, and they may not be classifiable mental health issues. They may be moral distress or demoralization or understandable human, sort of reactions to a situation. That where it crosses over into pathology is sort of irrelevant to me. It's people are distressed by an understandable situation. It can certainly lead to depression and anxiety or PTSD in post-traumatic stress disorder in an individual, but there is opportunity through our outpatient, mental health support services for individuals to get psychiatric care in that way. But I would say broadly as a system, the answer is no, right? I'm generally a positive person, and so I like to highlight where I think there are bright spots that could be scaled and disseminated across. So a positive sort of, and a lot of this, I should say, also, as many things in our system got disrupted by the pandemic. But there's actually in Ontario, there's a caregiver hotline now, right? A phone number that caregivers can call.
Yeah,
now,
through the Ontario Caregiver Organization,
yes,
they have their helpline, and maybe Jen or Christine can put that information as a link in the chat. Ontario
absolutely.
Caregiver Organization.
I haven't seen sort of, maybe you're aware, Donna, but I haven't seen sort of programmatic evaluation of sort of what user experience is like and what they're able to provide, because at the end of the day, they can hear people's concerns and they can direct them, but they need to have a well-stocked community of services and supports to actually refer people to, right? So I don't know the answer to that, but I think that's actually a good thing to think about, a sort of central number or resource that people can call to get information or to help them problem solve and to troubleshoot. I think something like the carers program that I spoke about at Mount Sinai is something that has already been scaled across the province, started off locally at Sinai. I think the work that you're doing with McMaster in terms of caregiver training, right, and thinking about providing people with the skills to be able to execute the tasks that we are asking them to do, these are positive things. They're bright spots. I would say, fundamentally, though, I think there's still a huge problem with awareness in our healthcare system, that healthcare providers, my own profession is very guilty of this, do not fundamentally understand what we are asking caregivers to do or what they're even doing in the background to hold things together.
Mhm.
And until healthcare institutions and providers, focus on both the patient and the caregiver or the caregivers and understand what they're taking on, that when you write a prescription for this medication or ask for this to be monitored and put that on a discharge piece of paper, that is likely going to have to be assumed by an unpaid family caregiver to execute that task, that person needs training, they need a number to call, that if something goes wrong, they may need some reinforcement in the same way that, when you purchase an item from a store and you can't figure out how to work it, there's a number to call or there's a website to look up, right? And so
Good analogy.
yeah, like if you're designing, I always say, if we designed a healthcare system, right, for the worst possible customer experience, I think we probably have that, right? You can't call anyone when you need them. They're not usually, I'm overly generalizing, but I think, where our healthcare system shines is if you are critically ill or you need some state-of-the-art therapy, we are magnificent in that, right? But when you are dealing with chronic illness and you're grumbling along, or you have a chronic condition that needs to be supported over the course of years, the time you're likely, and again, I'm generalizing, to get excellent care is when you have those episodic deteriorations and you end up in hospital. And it shouldn't be that way, right? The customer experience on the outpatient community setting is terrible. And so until we raise the awareness and the literacy of our healthcare systems to understand what caregivers are doing and what they actually need, and to be honest, do that with policymakers as well, to think about things about how to financially protect them, right? And to protect their careers and to protect their retirement savings so they're not liquidating those. We will continue to create these situations where, as you spoke about, we are putting people into situations that create moral distress for them, that lead to mental health outcomes that are deleterious for them, and that they're going to be left with feelings of guilt and what ifs and questions about what could have been done differently.
Yeah. And I think, there's certain truths that have emerged in my lived experience of being, I would say, an intensive caregiver over many years. One is that, like you said, if you're really sick at death's door, the healthcare system is magnificent in Canada. Although I guess I have to say that is true. But within the last, maybe, especially since the pandemic, there is more ableism and ageism baked into the system now. So I'm not even sure that the system will respond in such a magnificent way for people with severe disabilities or who are at the, very old and at the end of their life with multiple chronic conditions. What do you think?
Certainly our acute care system, beyond COVID and the catch up of sort of all the chronic illnesses that weren't, fully treated and the screening that wasn't done. I still fundamentally see every day that if you're coming in, and no matter who you are, and you are critically ill or you're acutely ill, if you end up in our hospital bed, you're going to get care that's world-class and meets the standard of care, right? You will be looked after. And again, I have a bias of being in a downtown, the Quaternary Center, University Avenue in Toronto, that has a specific, stated priority program of geriatrics. So I acknowledge that, but I generally think that that the healthcare system, for when you need, again, it may not be the best customer experience, right? And you may have to spend 2 days in the waiting room before you get a bed. Like, these are things that still shouldn't happen. But if you just zoom out and look at, are you going to get guideline concordant care that meets the standard of care anywhere in the world to provide you what you need for your acute illness? The answer is overwhelmingly a yes for me on that. So, and again, like, if you have a rare cancer, or God forbid, or you have a rare condition, there is someone in our province or in our country who is a world-class expert in that, who can provide you with world-class care. Like, that I fundamentally believe and hold true, and it makes me proud of our system.
Yeah, absolutely. And that's where I want to turn our conversation to solution making. You've alluded to a couple of really innovative, wonderful programs for patients and families. And I want to highlight too, I believe you worked with Dr. Samir Sinha through the National Institute on Aging on a particular model for emergency rooms for older adults with dementia and Alzheimer's. It's called, and I only just thought of it, so it's like ARCH or something. It starts with A. It's an acronym. But do you have special accommodations in your emergency room at Mount Sinai that, like, maybe lowered lighting or increased lighting or things that work better for your population of people you're treating with complex care needs?
Yeah, so I can't take credit for that. I work on a lot of things with Samir. The elder-friendly or senior-friendly emergency department wasn't my work. Maybe there was another thing which sounds like ARCH, which is the ACE unit, the acute care for the elderly unit.
That's what I'm talking about.
So we have both of them at Sinai. So yes, there are, let me give you a specific example. So delirium is a very common condition that affects hospitalized older adults. Up to sometimes, depending on the study, at 25%, a third of all older adults who admit to hospital experience delirium. What is delirium? It's an acute confusional state. So somebody comes in, they may have a medical illness, they become confused. At the most obvious extreme of that, it's people screaming out, confused, the room is on fire. At the least obvious, but equally associated with long-term poor health outcomes, someone's withdrawn, they're not engaging, they're not attentive, right? And those people are not noticed as much, right? And so one of my favorite clinical trials, which are a lot of the pieces that we bring in as part of our ACE unit, but also in terms of the program we do, is a trial published in the New England Journal of Medicine in 1999. And it's a preventative program for delirium. So delirium may be caused by an infection or a medication or a procedure that somebody had done. But once you have delirium, even if you correct the underlying inciting event, the effects of delirium can last weeks or months, even after you've corrected that event. So we really want to prevent it. And so in this program, they actually engaged high school volunteers and focused on 6 proactive measures to reduce delirium. So one was optimizing sleep. So you're going to think, well, are you looking at high-tech medicine? This is high-touch, low-tech medicine, right? So they actually did things like reduce the overall overhead pages. If you've ever been in a hospital, all you hear all night is beep, nurse to this room, doctor to that room. Like, no one could sleep in that environment. They took the pill crushers. Some of you may have heard, like, when they're crushing pills at the nursing station, it's like bam, 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 right? They created silent pill crushers, silent beepers. They had warm milk and chamomile tea available to people and relaxing music and background. So that was sleep. They worked with them to mobilize, to walk them a couple times a day to prevent them from deconditioning. They used whiteboards with orientation on them so they know who their doctor and their nurse is, what the date is, what they were in hospital for. They used pocket talkers, so people who are deaf or who are hearing impaired and often smartly don't come into hospital with their hearing aids because they cost several thousands of dollars, and we often lose them when they're being transported from the emergency room up to the ward. We provide them with a very simple amplifying device. Same with glasses and magnifying glasses and wayfinding within the environment. And then nutrition and hydration. Often the medical student will say to me, well, I saw Mr. Smith, they didn't eat their meal, they weren't interested. And I said, well, you have to think about it. A meal was dropped off in their room. They may not have their glasses. They have arthritis. It's all packaged in plastic. To open those things and they're in a bed, which is awkwardly positioned. Like, I don't eat like that. So they actually worked on these 6 factors, and they were able to drastically reduce delirium in a preventative manner. Those sorts of high-touch principles, yes, we've embedded within the emergency department in a physical infrastructure way, but also in terms of the care process ways. And same thing on the ACE unit as well. And there's some parts of that that are also proactive. So proactive consultation for groups like physiotherapy and occupational therapy and the social worker, because we know, coming back to our original conversation, But a lot of these people are complex and they need much more than a doctor to figure out their problems. They need other experts to figure out their problems. And so, yes, it's physical infrastructure, it's care processes, and it's the way we support people in a non-sort of surgical and medical way per se to make the experience of a hospitalization a lot less hostile, depersonalizing, and deconditioning to try and be proactive and to prevent that.
Mm-hmm. One of the most interesting things that I'm hearing about this is the use of teenagers as volunteers.
Yes.
Because I've often thought that that we need almost a victory garden approach, a wartime civil effort to get the human touch and the humanistic labor. You need to galvanize communities around this. And we're hearing in the chat some very sad stories and distressing stories about people continuously using the emergency room when there's no rehab provided and there's no follow-up. And so, which brings me to the question that I want to get into before we leave today is, how can we fix this so that a general practitioner, or even worst case scenario, somebody at a walk-in clinic, physician at a walk-in clinic, has a billing code for 90 minutes where you can self-declare as a complex care patient, or there's some way to flag you in the system on your medical record that you are a complex care patient, that kickstarts a suite of responses in the community and in acute care, in long-term care, and where families are supported as well. And as if some mechanism would press override on all of the maximum levels of services that are for the general public, somebody 40 years old with a broken leg or something. This is not, all patients are not the same. And we are talking about people with very high needs. How can we do this systemically so that we don't have to keep bringing our loved ones to the emergency room twice a month?
Yeah. I know you and I have talked about, like, how do we identify these people, right? So I think to start with the identification piece, we often already know without a qualifying thing who is complex in terms of the patients that we're seeing. Yeah, if you have advanced dementia, or you have dementia with behavioral symptoms, that in itself is complex, right? That single issue, forget about all the other issues.
Yeah.
And often we know that someone's complex and we are advocating for more services and supports. But of course, the LIN coordinator, they're in an impossible position too, whereas they are meeting budget cuts and competing demands, and they have a bunch of other clients. So ultimately, I think there are two components I would focus in on. I'd come back to primary care, which is that if we had a system where everyone had access to team-based primary care and the ability to work on and focus on these issues over years, you wouldn't need to sit down with somebody for 90 minutes and unpack your life's health history, right? No, that's the truth. Yeah. You would, that would already be determined. It would be an iterative chronic process where you'd be working with ideally longitudinally the same group of not only the physician, but the same group of allied healthcare practitioners who would be well compensated, felt valued, participate as equal members in an interdisciplinary healthcare team. So that's sort of one piece of it. The second piece of it is, yes, we can find some way to identify people as complex. I would argue we already have several measures. And in my patient population, we have frailty, right? We have the CHEST score, the MAPLE score. Like, there are lots of scores that have been developed by some people who are even affiliated with McMaster University that are excellent and validated scores that can predict high healthcare use, institutionalization, poor outcomes. The problem is we need that well-stocked community to be able to provide for these people once we identify them. And that's where that huge gap is, so that, the catch-all for our system is acute care, right? When things go wrong and we can't figure it out, We tell people to go to acute care because within that space, we have access to everything and the person's safe within that space. Patch things up again until we send them back out. So if we had access to team-based primary care for everyone to prevent things from deteriorating to the point that they got the crisis, and we maybe not inverting, but we raised up our support for home and community care to be equal to the amount of focus and attention we provide to acute care. Because I'm not saying we should take away one from the other, because we do have I work in acute care most of the time, but we thought more fundamentally about, greater investments in home and community care, because as you know, Donna, when we look at other OECD countries, we highly underinvest not only in healthcare, but also within home and community care as a proportion of our acute care system. Those two things, I think, could fundamentally make a big difference to a lot of patients. There are always going to be some people for which the emergency department is the best place for them to go, and that's not a failure. That's just the best place for them to go. And there's always going to be a patient population that's going to need long-term care or a home for them to live in. And that's also not a failure of their caregivers. And it's also not a pox on the home care system, because there are simply some situations that are so complex that even 24/7 care within their own home may not be able to provide for that. But I think primary care and greater investments in home and community care could unlock a lot of solutions for people and their caregivers who are dealing with complexity.
Mm-hmm. Well, I think so too. And I do think that hand in hand with that, we need to be thinking outside of healthcare systems and looking directly at communities to find those teenagers, find, it's support and galvanize communities so that neighbors are helping neighbors. If you ask caregivers in the trenches, what is the most helpful thing anybody has done for you in the last 3 weeks? It's usually food delivered.
Yeah.
So we need that kind of support, and we need to value it and support that support too. But I love this thinking about what is the complex care health pathway, and it's being teamed and increased resources in home and community care. So
and to Donna, to be like, there have been models of that were started in Ontario during the pandemic. There was something called the HISH, High Intensity Support at Home program. That was a time limited program during, around the pandemic, to keep people in their homes rather than bring them to the hospital. But what was the goal of that? To protect acute care during the pandemic, right? And then as soon as the pressure off acute care came down, these programs dried up and the funding dried up for them. So, and I can't remember all the qualifying criteria, but it was a lot of what we talked about. Like, we know who these people are. It's just that we need the resources and supports to provide for them. I think also your point about community and engaging young people and intergenerationalism is so important. One of the things I didn't speak about, and hopefully won't end on this negative point, but there is ageism, right? There is ableism. There's dementia-related discrimination, and these all intersect in a way that hinders funding, it hinders engagement of people. And because of that, I think far too often, these people live in silence, and people within the medical profession, but also people within the community, don't have the opportunity to engage with these people and to understand that just because someone lives with dementia doesn't invalidate them as a person, doesn't mean they can't do productive things as part of their life, doesn't mean they don't have things to contribute, doesn't mean they have wonderful stories and interactions to share. And so if we can shine a light on these people and bring people out of the shadows, I think we would also have a society that's more motivated to work on fixing these problems. But we keep people in silence, and we think of dementia as an embarrassing and ugly diagnosis that shouldn't be seen.
Yeah, it's funny, I have a dear friend who has early onset Alzheimer's, and we have a girlfriend circle, and I go once a month with another friend. So we found two friends visiting our friend. Works best because it takes the pressure off the conversation. It's all very natural. we love hanging out together, and she's still so much of herself in many ways, you know? So I think of those times, those Tuesday afternoons, you know, as a real gift in my life. And it's not that complicated, you know, it's kind of easy to do.
Yeah.
So I think that there are bright lights that we can look at, but we need to keep our eye on the prize of creating these pathways so that people don't have to alone in the community without support try to figure out how to put one foot in front of the other and keep going, when the only options really look like calling 911 or doing nothing.
Mhm.
Right. So I just want to finish. I want to, because we had this question come in numerous times, Nathan, another very practical question. What do you tell your family caregivers of patients on your caseload? When is the time to say it's time for long-term care?
Yeah, that is that is such a tough question, right?
Yeah.
I think firstly, one question I always try and ask caregivers, and they're always shocked when I ask them, is how are you doing? Right? They rarely in all their healthcare interactions get asked how they're doing. They're just seen as a person in the room who is there to accompany the person in the clinic and help provide a history for you by most healthcare practitioners, unfortunately, and to execute the tasks that you're going to develop during your clinic visit. So I think that open-ended question, while it's so simple, can really uncover a lot to understand where a person is in their caregiving trajectory, how much longer they can hold on for. Some of them are actually surprisingly thriving and getting great meaning and purpose out of their caregiving experience. Like, it's not all negative, as you know, right? For some people, it's a tremendously gratifying experience for them. I think one of the fundamental issues that sort of relates to how our healthcare system was developed was we often don't consider non-cancerous illness as palliative illnesses to some degree, right? And so, dementia is actually a palliative illness. It may go on for years. The person may never die of dementia. They may die with dementia, right? And die from something else. But the same principles apply because we don't have a curative therapy for dementia. In fact, we don't even have a disease-modifying therapy for dementia. And so having early conversations where the person with dementia and their caregiver can participate are key, and then reassessing that care plan that was established up front are really important. So often at diagnosis, I bring up to people, you should get a living will, you should designate your powers of attorney. And that process uncovers sort of when it might be time for someone to enter long-term care, because when that has happened, right, it's often at a point where the person with dementia may not have that insight that we spoke about, right? And they may not have the ability to recognize the stress that they're putting on that caregiver. So, there is no right time, and it shouldn't be viewed always as a negative sort of failure of caregiving. It's often a necessity for people. But I think early discussions and planning are key to making that decision and that process less painful.
Yeah. Oh, I couldn't agree more. And the Canadian Hospice and Palliative Care Association has a lot of online resources for advanced care planning. And there's a website called advancedcareplanning.ca, where a lot of the tools and resources to have these conversations are right there.
Yeah.
And they make a very strong argument for having those conversations early.
Absolutely.
And my husband and I just finished doing that we redid our wills and we did our advanced care planning and what do we want for ourselves? So it takes the pressure off our kids. We did it for our daughter, so she wouldn't have that be in the position where, I don't want to make these decisions when I don't know what mom or dad would want.
Yeah.
So,
or even for each other. You may sleep within bed with someone your whole life and you don't actually know what they want.
it's true. It's true. So we were very relieved, actually. It felt like a weight off our shoulders, and it's not that hard once you get into the thick of it. And
Yeah.
so I urge people to do that advanced care planning. But we're at the top of the hour, and I just want to thank you so much, Nathan. What a rich conversation. I think we solved all the problems of the world. Now the politicians just need to listen, right?
Absolutely.
Yeah. Oh, thank you. So over to you, Christine, for some announcements.
And thanks for the opportunity. To
Thank
McMaster,
you.
to you, Donna. Really appreciate it.
Thank you.
Well, as always, these talks are always so informative. And I don't know, Dr. Stoll, if you've had the opportunity, but people are, always sharing their own experiences. And it's a wonderful community that has been created through these webinars. I do want to ask though, so someone had asked, because Jen and I are trying to put the links in, and someone is asking, could we repeat the Canadian Palliative Care resource again? I didn't get that one either.
Yeah, sure.
To help. I think Michelle was asking that.
Yep, I'm just putting that link in the.
So thank you all. Donna is putting that in. I want to thank everyone for joining us once again. I hope you found that as informative as I have. This particular topic was close to my heart because my mother-in-law is in her late stages of Alzheimer's, and the struggle. We see the struggle. They just live down the street. So thankfully, my husband and I are able to help out with our 2 teenage daughters, which I think, you talk about that intergenerational. And it's interesting to see teens learn compassion, right?
Mm-hmm.
When they see my family's Italian. So when they see their nonna, not the same person that she was a year ago, not even the same person she was 3 months ago, sitting with her, I think is important. The kids learn compassion. So hopefully my children will not engage in any type of ageism as they move on into their careers. So Donna and I are working on the next talk, which will be in January. We're still trying to confirm the speaker. We have some feelers out. We're hoping to have that sort of mid-January. So look for that in your inbox. We had a wonderful, this is the last session of this year. We have had a wonderful turnout. So thank you to everyone. For those of you joining us for the first time, we hope you found this informative and engaging. And for those of you who maybe this is your 3rd, 4th, 5th, or 6th time that you have joined us, we really appreciate you advocating and letting people know that this series is available. So with that, I think Donna, Dr. Stoll, and I will wish everyone happy holidays as the holiday season approaches. Hopefully for those of you in caregiving roles, it's not overly stressful time of year. And we look forward to seeing you all in the new year. Thank you, everyone. Thank you,
so
Dr.
much.
Stoll. That was wonderful.
Thanks,
Thank
everyone.
you.